Good morning. Want to call the hearing to order of the Select Committee on Infectious Diseases in High-Risk Disadvantaged Communities. My name is Mike Gibson. I serve as the chair of this particular committee. Hepatitis is the seventh cause of death in the world and growing each and every day here in California. Cases of hepatitis are increasing every year in our state and also in areas of communities that are mostly those communities of color.
In terms of hepatitis C, it's a virus that's transmitted primarily through blood, both in the U.S. and nationwide. It's a leading cause of liver cancer, liver transplantation, and liver disease. Our back-of-the-envelope estimates indicate that there are approximately 600,000 to 750,000 people living with chronic hepatitis C in California. But again, we don't really know because the prevalence estimates from the national level don't include people that are incarcerated, people that are homeless, people who we know are disproportionately affected by hepatitis C infection. Nationally, hepatitis C deaths now outnumber deaths due to HIV and have since 2007, and that trend is only increasing.
Overall, hepatitis B and C affects about 6 million people nationwide. If left untreated, chronic hepatitis B or C may lead to cirrhosis, liver cancer, also liver transplantation. And worldwide, actually, liver cancer is the second deadliest cancer. New treatments, the direct-acting antivirals, cure rates now are over 90% in general. This is compared to the interferon era, where 2/3 of patients were cured at best, and the treatments are extremely toxic. Screening at-risk patients and providing access to these powerful new therapies is our next and greatest challenge. Both screening and linkage to care for chronic hepatitis C is poor. About 20% of patients who are at risk are actually screened.
How do we begin to spread the word, one, about the treatment that exists?
So, there's a lot of misconceptions out there. There's a lot of this, I feel well, therefore I cannot be sick, I cannot have this virus inside of me. And it's really educating the public, it's educating even physicians, who are outside maybe the liver specialty, that, these patients need to be screened. If they're within the baby boomer population for hepatitis C or from these immigrant populations where hepatitis C is worldwide, they need to be screened as well. So I think breaking that kind of, that inertia of saying, why don't we just do the confirmatory test to be sure that everyone really is fine, instead of just saying they are and then, something bad happens in the future. For our part, we're, really just going out to the different areas and trying to find people, because our experience is that they don't generally come to us.
To this day, asking my mom to see a hepatologist is almost like pulling teeth. Like so many others from her generation, she believes that what she doesn't know won't hurt her.
And the medication was available for this last bout after the transplant that ravaged his body. The first reading was just off the chart. And it went like that for quite some time because we couldn't get the insurance to pay for the very costly medication treatment. It's devastating. People are dying. Where's the humanity in that?
Beyond sort of the traditional medical system, what do you believe is needed to increase hepatitis B and C testing and linkage to care in communities most impacted? What are some ways, sort of outside of primary care, to reach people with testing services and linkage to care, given that we have such a large testing gap and a lot of people with Hep B and C who don't know it?
Really a lot of trying harder and getting out into the community, seeing if there's any organizations, for example, that would like for us to hold a health fair, for example, an educational fair. So, we're partnering with, some, there's places of worship, for example.
And if I may, I would just add, I think some of those other non-traditional venues for screening might include syringe access programs, homeless shelters, and hopefully these projects that Rachel referenced will help identify what are the best places to reach people who are living with Hep C and don't know it. Also, jails and prisons are important venues, and drug treatment programs as well.
One of the collaborations that we've been developing in the last several years has been with some of the tribal health clinics, both with the California Rural Indian Health Board, the Indian Health Services of California, has been implementing a hepatitis C program, and we've been providing them with training and technical assistance to sort of support them in those efforts. American Indians and Alaska Natives are one of the groups disproportionately affected by hepatitis C in California, so we're really excited about that collaboration. I also think that there are exciting developments happening on the Medi-Cal side in terms of expanding access to medication-assisted treatment for opioid addiction, which amazingly has actually been shown to reduce hepatitis C infections. So I think if you have a combination of syringe access, hepatitis C treatment, and medication-assisted treatment for opioid addiction, the three of those together have been shown in research models, at least, that if you combined all three, you really can reduce the prevalence of hepatitis C in the entire population. But I also think one thing everyone has been speaking to is it's really important to kind of meet people where they are and not kind of sit around and wait for them to come to you.
Again, thank you, panel, for giving your testimony. And thank you for the family members who have, one, lost individuals and those who are surviving. We certainly believe in you, and thank you very much for providing such emotional and heart-wrenching testimony. This concludes our hearing, and thank you very much for coming out. Thank you.